to everybody who has joined today. I know time is precious, and I know you guys are all doing important, critical work. And like Tamara said, if there's something that I'm not able to answer, or you have a further question or a very specific question, at the end of my presentation, I'll have my email address. Please feel free to reach out. I'm happy to answer any of those questions or set up a time to chat because we only have so much time. Like Tamara said, my name is Quinn Nystrom. I'm here from Minnesota, cold and rainy today. But really happy that everybody could join, and we are going to dive right in. So a little bit of an introduction about myself. As Tamara said, I was diagnosed with type 1 diabetes when I was 13 years old. So I've lived with type 1 for over 25 years. It was actually around about a year after I was diagnosed with type 1 diabetes is when I started struggling with an eating disorder. In my early teens, it presented as anorexia. I grew up in a very small town in Minnesota. We didn't have eating disorder specialists. We didn't have therapists who specialized in certain kind of areas. And so we were at the family pediatrician, and the family pediatrician said, yeah, I think she probably has an eating disorder. My best advice for you is watch her at breakfast and dinner, and make sure she's eating lunch at school. And so, for me as a teenager who was struggling with body image and appearance, and I was a competitive figure skater, I thought, well, you've really left me off the hook here. And so there was not really any kind of follow-up to that. And getting diagnosed with type 1 diabetes at such a young age, especially back in the 90s, it was a very different world of how healthcare professionals were taught how we manage the disease, and also the education that was given to us as the people with diabetes. It was very regimented. It was very black and white. I would say 25 plus years ago, and probably a lot of practitioners on this call could relate, there wasn't a big focus on language that we use and how that impacts patients for the good or the bad. And so, I had this sort of lived experience for all these years. I was living with type 1 diabetes. I ended up not getting sort of I would say real professional help until I was about 24 years old for the eating disorder, which had turned into bulimia at that point. And I was always frustrated from the information that I was given, either those first experiences when I was told that I had an eating disorder, or those first experiences when I was told I had type 1 diabetes. And I knew, and I want to say this at the top of the hour, I don't believe that any clinician, any provider has an ill intent with the language that is chosen. I think you guys are very busy. You have a lot of information, a lot of changing landscapes with a lot of different things that you're managing. And I don't think it was always at the forefront, probably, of the educational experience about what are the words that we use when we're talking to people with diabetes or talking to people with an eating disorder. And so I went to college for mass communications, ended up getting my master's degree from Syracuse in communication, and did research around communication messages from various groups: friends, parents, healthcare providers, media, social media, and how that impacts somebody's self-efficacy. So again, one's confidence in being able to self-manage. We know with type 1 diabetes, and also with, somebody living with an eating disorder, you are making the decisions pretty much every day, every hour. Yes, hopefully you've gotten assistance from healthcare professionals. But you're really the quarterback, and you're making those decisions. And so what is that confidence that you have in yourself to take that information that you're learning, maybe in a 1 hour appointment, or even a higher level of, partial hospitalization or residential treatment. But then when you come back home, come back into the real world, and it's just you, or maybe just you and your parents managing something, what is that confidence level? So, and so for me, I think a passion came from, again, wanting to talk about that lived experience, wanting to talk about maybe things that got missed along my story, along my journey. And certainly, I don't think I'm special or unique in any certain way. But now, having spent a career as a professional speaker and writer and consultant in kind of the diabetes eating disorder world, hearing from other healthcare professionals, hearing from other people with a similar lived experience than me, or different lived experience than me, I've really tried to take that to try my very best to communicate then to people who interface with people with eating disorders and diabetes on a daily basis. How and why are we putting this emphasis on the importance of integrating that lived experience into clinical understanding? So again, beyond the numbers or beyond the DSM-5. So that's what today's presentation's really going to be focused on. So the learning objectives, again, really describing the lived experience of living with an eating disorder beyond maybe what we would just read in the diagnostic criteria. We're going to identify key factors that support resilience and recovery in individuals with eating disorders, maybe, beyond a textbook or beyond a training. Also applying trauma-informed, person-centered approaches in clinical practice. So, a lot of this information now that we know about adverse childhood experiences, how that plays a part, customizing, I think, our treatment and sometimes the paths that we give to a patient and families of how best to combat things. And then lastly, recognizing the clinician's role in fostering hope and long-term recovery. I am an optimist, and sometimes I think we hear sort of that word fostering hope, and it just seems kind of, I don't know, woo-hoo, or, it kind of frilly. And it's like, okay, no, we gotta get to the hard information. We got to get to the textbook. But I'll say, in my now probably 20 years of speaking around North America, when somebody lacks hope for their future, it is very hard, I believe, for them to really have that skill of self-efficacy, of having the self-confidence and working. And because the truth is, just like living with type 1 diabetes, which is pretty much just a roller coaster of managing blood sugars, but living with an eating disorder, you will not hear me use the word recovered as in past tense. And the reason why is because I believe, even though I'm in recovery, I choose recovery on a daily basis. For me, I will always have bulimia, and it's figuring out on a daily basis. Some of those days are easier than others. I was just telling Tamara, I was frazzled rushing in here. I had my lunch to the side because I was stopped by a train and I was running late bringing my son home from nursery school to drop him off at the daycare to do this webinar, right? And I had a decision, right? Do I try to get a small luncheon, or do I just skip it and say, well, my day's busy, I'll get to it later? And so for me, it's making those conscious choices daily, but sometimes hourly, of how I'm committed to my recovery. And I think that hope plays a crucial role in that long-term recovery piece of it. So understanding eating disorders, again, I know I'm probably speaking to the choir with a lot of you on this webinar, but for some who may not be as familiar with the DSM, when I refer to that, that is the Diagnostic and Statistical Manual of Mental Illnesses. And it's kind of the American Psychiatric Association's kind of go-to reference book on mental health and brain-related conditions. We have been on the DSM-5. That was first published in May of 2013. And then there was a little bit of a revised version that came out in 2022. But this is what providers, when I went in, again, when I was 24, this is what they were looking at when they were looking at, okay, the diagnostic criteria for anorexia. What are those, right? Those are bullet pointed. What is the diagnostic criteria for bulimia or binge eating disorder, or PTSD? And it's listed and it's black and white, and it's what providers use and kind of what is universally recognized. And also when we get into health insurance and all of that stuff, which that's a whole other presentation. But this is kind of the Bible, shall we say, of what people are referencing. And so, again, I think it's black and white, and it probably needs to be black and white. But I'll say for myself, you know, what the DSM doesn't cover, I mean, is quite a lot. Here I am as a young girl, as a teenager, around the age when I was diagnosed with type 1 diabetes, around the age when I started struggling with anorexia. You know, my internal experience was I grew up in what I thought was sort of an idyllic childhood, with a quote unquote normal family, upper middle class, parents that were involved in the church and the community. You know, I was told that I had anything that I wanted. I was in figure skating, and those, when I kind of started in the competitive realm, is when I started getting a lot more self-conscious about how I looked, comparing myself to other people. There were things that happened to me as a young child, a passive sexual abuse, a molestation that, again, was very hidden in me. And for whatever reason, I felt I could not speak about it. And I didn't realize how I was internalizing all of that as a teenager and into my young adulthood, and how that was forming how I approached things, and also how I managed stress and other trauma that was coming up in my life. And, you know, I knew from a fairly young age that I had been diagnosed with a chronic incurable illness. I don't think I realized what I was also going to be at a higher risk for. So when I was 13, you know, the way, actually, I was going through some boxes earlier today, and if there's some dietitians or diabetes nurse educators on this call, I found the old books from the American Dietetic Association about the exchange lists for meal planning for people with diabetes. I found an old book by an insulin manufacturer on managing your diabetes, and talking about pattern management, talking about good choices and bad choices when it comes to food, good foods, bad foods, talking about exercise, talking about body image. And, you know, I think you just kind of take that in, and it's given to you just like in a classroom, like, here's the information. And then I'm internalizing it as a teenager who's now struggling with body image and an eating disorder. And I'm not thinking, oh, this is diabetes education. I'm thinking, well, they're telling me this because I'm overweight, right? Because I don't look like everybody else. I need to lose weight. I need to cut corners because I'm being forced to do this kind of diabetes diet, or to eat when I have a low blood sugar and I don't want to eat, right? And so I think it just kind of set me on this course, and not knowing what could lie ahead. I don't think it was till, I don't know, probably 20 years after I was diagnosed with type 1 that I found out that a young woman with type 1 diabetes is 2.5 times more likely to get diagnosed with an eating disorder in their life. I didn't know that. My family didn't know that. Would it have changed some things? Maybe, maybe not. But I certainly think it would have been good information to have, um, to try to catch things a lot earlier than when they were for me. And adverse childhood experiences, I think we are talking about that so much more here in the last couple of years. But again, for me, it's probably been recently, after going to residential treatment for an eating disorder. Then I sort of had my bulimia kind of in a recovery state. And then I switched right to alcohol and was struggling with alcoholism. And, I thought, well, the bulimia is under control, right? I'm great now. But then I was a closet drinker. But because, again, nobody when I was struggling with an eating disorder, I didn't have people coming to me saying, oh, Quinn, we're really worried about you. You don't look well. You're acting kind of out of sorts. I didn't have that. I didn't have that trigger. I didn't have a healthcare professional asking me those kind of pointed questions. And so I never provided it. I wasn't really willing to give that information. And same thing when I became a very problematic drinker. I was able to hide it very well because, again, from my childhood experiences and the family that I grew up in and the environment that I was raised in, it was very much about appearances, looking a certain way, acting a certain way. And I can reflect back now, and I know my parents did the best that they could with the resources that they had from their own childhood. But it was very much a mentality of, we do not speak publicly about any family issues, any family problems. As long as you're not on the side of the road dying, you're fine. Somebody has a lot worse than you, and you need to pull yourself up by your bootstraps and keep going and keep quiet. And you're going to, I'm going to quote Taylor Swift, but I didn't mean the reference, but protect the family. And that was very much the mantra in my family. And so, digging into kind of ACE scores and seeing, okay, the score is based on 10 types of childhood trauma. 5 are personal, right? Physical abuse, verbal abuse, sexual abuse, physical neglect, and emotional neglect. 5 are related to other family members that you may be live with or have close experiences with. This was really started back in the mid 80s by a doctor, and it had its origins in an obesity clinic. This is in San Diego, and trying to figure out, right? There was a physician who was getting all these patients, and he was just trying to figure it out and trying to figure out how people got to him, and how we figure out some complex medical issues. And And so that's when he really started diving into this. And as some of you know, out of those 10 questions, you get 1 point, and the higher your ACE score, the higher your risk is for disease, social and emotional problems into your adulthood. And so, uh, again, I was being raised in a pretty typical American household. Um, Things like abuse or family dysfunctional behavior was not discussed. And it was like, we are blood, we are family. Um, you stick to that, and we don't talk about stuff outside of the family walls. And that was explicitly told to me as a child into my teen years and adulthood. And so when we see this kind of, this research that has been done, right? We're talking about the abuse. We're talking about the neglect. When I think of the word neglect, I think of, was a child left at home by themselves, right? That's what I automatically think when I hear the word neglect. I don't think of it, though, as were the emotional needs neglected of a child, right? So it's not just about, were they fed, were they clothed, did they have a roof over their head, but what emotional tools did they need uh, to be equipped for life, to be able to overcome various challenges that were going to come to them, sometimes by choice and sometimes not by choice. We also see on household challenges, right? When it's talking about the other 5 points, was there a divorce? Was there somebody close in your life who was incarcerated? Did you have a parent or somebody living in your home who had substance abuse issues? Was there domestic violence? Again, I will say, before I went to residential treatment and found providers who could communicate to me in a way that made sense to me and could say things in sort of layman terms, I would hear something like domestic violence, and my definition just automatically in my head is, let's say a practitioner said, Quinn, have you ever experienced domestic violence? And I would say, oh no, I don't really date anybody. I'm pretty much a kind of a single kind of gal. Because to me, domestic violence is partner to partner, a romantic partner. That's what I thought it was. And I thought, okay, if I had a significant other who was physically harming me, that's what domestic violence was. So very black and white. And again, who knows how I came up with those definitions, or if that from the sources that I was consuming in the media or movies, or being told in different settings. But I didn't know, I think, how domestic violence can be any person to person, right? In close relationships. It can be a family member to a family member. And I'll never forget when I was finally able to get the diagnosis of bulimia, and I was in and out of sort of partial hospitalization, intensive outpatient, individual counseling, because I was not open. I was not an open book. I did not want to openly share about my experiences. I didn't really think of myself as somebody who had bulimia or struggled with alcoholism or struggled with body image. And so when I went to residential treatment for the first time, and my individual therapist said, I'm going to put you, Quinn, in, with your schedule, I'm going to put you in the domestic violence survivor group. And I remember I looked at her and I said, what? Like, are you looking at the right chart? What are you talking about? And she said, you're a survivor of domestic violence. And, I was in my mid-20s, not married, no relationship with a significant other. Obviously, we had delved into family dynamics and experiences and relationships. And it was then that I realized that a relationship that I had in my immediate family for years absolutely was domestic violence. Now, the behavior was consistently normalized by family around me and around us, but it was verbal, it was physical, and it was repetitive for years. And until somebody could really explain it, it didn't click to me that I had ever experienced that type of violence. Mental illness, again, either myself or other members of my family, what people may have been struggling with. I would say we've made a lot of great strides with how we talk about mental illness in 2026. I will say I still think we have a long way to go to stop the stigma around it. Also get way better health insurance coverage for it. The truth is health insurance does not look at a type 1 diabetes diagnosis and treatment the same as it does in eating disorder, bulimia diagnosis, and the treatment that a eating disorder professional would recommend. Those, I believe, still in 2025 are not evenly given the resources. Or when I was at this residential treatment for the first time, I went to residential treatment twice. And on day 6, the treatment center's health insurance individual came in and said, Quinn, your insurance is not covering this. They do not believe that you are sick enough to need residential treatment. And they said, there was backlogs. And so we're just finding out now. So either you're going to have to get discharged today, or you need to pay for the last 6 days at the cash price and then prepay ahead. And I just remember being absolutely devastated because I finally felt, after 12, 14 years that I'd gotten to a spot where I was ready to open up, where I trusted the team that I was being given, that they understood me, that they were empathetic, that they were patient with me, that it was going to take a little bit to get things out of me and for me to be open to learn different things like DBT, dialectical behavioral therapy, or CBT, or I was going to start acknowledging things of my past. I needed that time. And, a doctor in a cubicle and who knows what state determined I wasn't sick enough, right? I wasn't, in their opinion, I wasn't at a low weight. I wasn't at a certain BMI number. I wasn't at the time homicidal or suicidal. And those are the things that I think we come up against when you may have a client sitting in your chair who you may think seems defiant or hopeless or lacking motivation, but they may have been discouraged. They may have socioeconomic issues that we cannot fathom, right? I often see this in the diabetes world around the issue of insulin affordability. I don't think anybody in this world doesn't want to take insulin because insulin is life support for somebody with type 1 diabetes. But oftentimes, maybe our job does not provide the right coverage. We feel ashamed because we cannot pay for our prescriptions that have just gotten astronomically expensive. And you sort of do the, I don't want to swear, but like you do the sort of F it, right? Where you're just like, F it, I'm done with this, right? Why do I even try if like I just fail, or I wake up in the morning and my blood sugar is not in this perfect range that I'm told? Because even though it may be out of my control, I take it very personal because these chronic illnesses require so much self-management and self-decision making it becomes very self-defeating. And so I think there's just a lot of pieces of people's stories that, again, we don't see listed in a DSM-5, that maybe we don't hear in a training, but play a very crucial role to maybe why that diagnosis is present, and also of how do we provide hope and a future for individuals to be able to look forward to know there are possibilities, to know that, yes, recovery is not linear, right? That it's going to be up and down. And some days you're going to think, I got this. And some days where I'm going to be like, I could not possibly make poor choices for my life. And so, again, how do we get that person to always know that there is hope and to always try to refocus on making the next best decision for their life? You know, we've seen the ACE study results, right? Childhood trauma, very common. Again, even an employed white middle class, college educated, great health insurance. You know, I never thought I was somebody who experienced child abuse, even though years later I can tell you, yes, I absolutely did in XYZ ways. I never thought that at the time. And we see that there are these direct links between this childhood trauma and an adult onset of chronic disease. So we know that the more types of trauma increase the risk of health, social, and emotional problems. You know, we've had so many studies done on this. We know that people usually experience more than one type of trauma, right? Rarely is it only sexual abuse or only verbal abuse, you know, one or two times. We know that oftentimes we see a pattern. And again, we don't see it just with one relationship that they have, but possibly multiple relationships or in different settings in their lives. So people who have experienced 4 or more of the childhood kind of exposure, right? We know through research, they had a 4 to 12-fold increase in a health risk of alcoholism, drug addiction, depression, and suicide. And when I hear that, I mean, not that I want to say, looking back on my childhood, it's almost like the writing was on the wall for my future, because I don't think of that, but I think there's a lot of things with having had healthcare professionals, knowing my life experience, knowing different words that we can use, different types of questions that we can ask, right? That if the totality of my health and my lived experiences had been laid out, that I think we could have been a little bit more proactive in looking at preventing things or catching things earlier, which often lead to better disease outcomes later on. Again, we see a 2 to 4-fold increase in smoking, poor self-rated health, 50 plus sexual partners and STDs. Again, we see a big increase in physical inactivity and severe obesity. You know, you can Google me and see I have a lot of presentations about diabetes, and I will get up on my soapbox about the shame and stigma that is put on people with type 2 diabetes. And people want to simplify this thing and say, well, that is an obesity disease. Somebody ate their way in and they can eat their way out of either a diagnosis or curing themselves. And again, we are still so far behind in 2025, I believe, of understanding obesity and the disease and what causes it in different people. And it's not the same in every single person that has type 2 diabetes. We also know that not every single person with type 2 diabetes in this country is categorized as obese. But again, there is a clear picture oftentimes told in the media type 2 diabetes, and then it's like a shot to the food court, right? With people drinking a big gulp or having fast food. And so there's a lot of shame and blame that I think is internalized, and people who do not get the help and the resources that they desperately need and deserve, because of all that is being contributed. Again, so the number of categories of adverse childhood exposure shows a graded relationship to the presence of adult diseases, heart disease, diabetes, cancer, chronic lung disease, fractures, liver disease. I mean, it is really astounding when you look at this research. And for me, I can be honest, my ACE score is a 6. I scored a 6 out of 10. And I can certainly tell you that if people were just kind of looking at my life, I don't think they would have guessed I had a 6 out of 10 on that score. Because I could very well hide things. The environment allowed me to hide things. My privilege and my upbringing allowed me to hide things. And again, I don't think my parents meant wrong. I think they also had their own childhood trauma, and they were doing the very best that they could with the resources that they had available to them. But we see that generational trauma that gets passed on and passed on and passed on. And if we don't address it head on, it can destroy families. It can destroy generations to come. For me, learning about my score for me provided a direction to heal. The key concept about, PACEs is that learning about both together, it can help improve our health and well-being. It gives us hope. Now, some people may say, well, how does that give you hope? I mean, isn't that kind of a downer? Isn't that kind of you're being hyper focused? Or maybe, Quinn, you didn't even realize, right? You were a survivor of domestic violence. Now you're being told you are. Wouldn't that be detrimental to your recovery? And again, I'm an opinion of one with my own lived experience. But what I would say is that when I was told things and educated about ACE and how if various things were present in my childhood or events had occurred, that maybe it explained things later on in my adult life, like why I felt hopeless in my 20s. I had a major relapse with alcoholism in my 30s, and I felt hopeless. Like, how do I get myself out of this? I felt I could only survive by having a quick release. And for me, bulimia and purging and controlling food and exercise, that was a way for me to feel like I was in control of something. In a way, too, I think it was also a way that I punished myself because I had such a low self-esteem. I thought so little of myself because I believed so many of those voices that I heard early on in really critical relationships who, again, now as an older adult, I can see there was mental illness struggles in some of those individuals who also desperately needed help and were not getting it for whatever reason. But I always looked at it as the context of like, well, that's my sibling. That's the person that loves me. Like, they know me the best, right? We've grown up together. They would only be telling me the truth. Like, they are my truth teller. And so I think by having providers explain to me how these experiences, again, to most no fault of my own, were setting me up for other chronic conditions, right? Or once that I got into a good or healthier place with bulimia, I was told years ago, the first time I went to residential treatment, when I left, they said, look, you have a diagnosis of alcohol abuse. We wouldn't say you're a full blown alcoholic and how things are presenting right now. But what we're going to tell you is somebody with your history and with bulimia are X amount higher of having a prevalence of alcoholism or drug addiction. And we would encourage you to not drink because we believe this could be a problem down the road. And of course, I thought, what do they know? And down the road, what was I going to treatment for? Alcoholism. And so I was just changing out what that quick release lever was for me in my life. My life was so chaotic, and I felt like some parts of my life were so shitty that like I deserved to get a quick release. I deserved to have that secret path to escape. And I was setting myself up for failure. When I think a lot of this really helped me to normalize things and also feel like I wasn't alone. Myth versus reality. We're told eating disorders are a choice. They're cured by eating. They're only diagnosed in teenagers. They're only diagnosed in girls and women. Sometimes they're caused by parents, maybe a mom who struggles with her own eating. Found in people who have type 1 diabetes. And if you have an eating disorder, the only type of symptom that would present is that you omit your insulin, right? So very black and white. Or that an eating disorder is not very serious. So again, all of these sort of myths versus reality coming out. I think in our culture, we see stigma, we see silence, we see systematic gaps all around, even though we are the wealthiest country in the world and the most developed country in the world. I'm a spouse of a military veteran, and I see it front and center in military culture. We could turn on the news and see what high up officials are telling generals and top people in our military about their physical appearance, right? And those are the sound bites we're hearing. Or we're seeing pictures of people getting discharged from the military and saying, by just looking at a sideway photo, that is how we're going to decide if somebody's fit for this. Having children myself now, I see the words fat and big and how I was raised and how I always viewed them as derogatory or negative. And I have a 9-year-old stepdaughter who has really helped me evaluate the language that I use. When she comes off the bus and is crying and telling me stories about people name calling her, using the word fat or big, and instantly as like a parent, I want to be like, no, you're not fat, right? You're not big. Like what? I want to be like mama bear. And the truth is, when did the word fat become this negative connotation? I have a picture of this book because my 9-year-old is the one who told me about this book. And I just love it. It is a beautiful book. And as an adult, I've learned a lot from this, that taking up space is not a bad thing. And so as a parent, I also need to mirror back language, how I look at things, how I talk about things, how I talk about other people that I see when my children are ever present, right? We still have this lack of understanding and awareness, and the impact of social media. I have a 16-year-old stepdaughter. I cannot imagine being a high schooler right now in this world and the pressures and the social media algorithms that we see that target you, and they target your insecurities. And it is, it's scary. And sometimes I feel like you're playing a game of whack-a-mole. You get one thing down and then another thing pops up. And so again, it is easy to feel hopeless or exasperated or just desperate, like I don't know what to do. And I've learned as a parent, sometimes I have to say, I don't have the answer, or that sucks. Like, I can't fill in stuff to just try to make my discomfort be what the focus is. Sometimes I have to sit with my kids' discomfort in the world that we live in today, or the world that I lived in as a kid in the 90s. And I'll touch on this again very briefly, but and actually I think I submitted this PowerPoint this summer, which kind of makes the cartoon even more ironic. Survey finds growing distrust in government, right? We have so many barriers to care, medical, psychological, cultural. We know, again, my own experience, denied residential treatment because somebody in a cubicle, again, probably thought it was too expensive and I could get by, and they didn't want to pay for it and they thought they could get away with it. I met an individual last summer who, again, on the surface level, maybe you would say they're not a compliant person with diabetes. They don't care about, going to the doctor. They don't care about taking their medication. But the truth is, there was underlying mental illness. There was a massive distrust for our government and our healthcare system. This individual was homeless. They were uninsured. And so there were, I was just sort of naively saying, well, in Minnesota, we have an emergency insulin program. You can walk into any pharmacy and they will distribute insulin for you on the spot. Well, you need a valid prescription for insulin, which means you would have to be going to a medical provider to have one that is not expired. And again, this individual didn't have that. So what barriers then did we have to overcome just to even get a prescription written for somebody whose pancreas stopped producing insulin 20 years ago, right? Or I have a dear friend named Huda here in Minnesota, and she taught me so much about her religious background. And again, different approaches and specifications that you take depending on somebody's religious background. Again, not making some snap judgment about something, but coming with them, asking them questions, not making assumptions, right? Or not putting everybody into, okay, well, if you are a Christian or if you are a Muslim, then you are XYZ, right? Like, this is a treatment plan we're going to give you if you are presenting with an eating disorder or if you're presenting with diabetes. That just, it doesn't work. There's so much variability to that. And I think that's why providing hope and a future and asking open-ended questions to people who are struggling is critical in healthcare settings. When we're talking about resilience in recovery, there are a lot of protective and promotive factors, right, that we know about. Supportive relationships. When I was really into my eating disorder and I was really struggling with alcoholism, I would cancel stuff with friends. I would cancel stuff with family. I would isolate. I was by myself. I was at home, right? What indicators could that have been given to family or support people around me that I was struggling? I could make a pretty good excuse out of getting out of something, but this repetitive pattern, what is my identity beyond struggling with an eating disorder or beyond being a person with diabetes, right? What are things about me that I love, that I'm passionate about, that motivate me? When we talk with young people with type 1 diabetes, the motivating factor to them typically to, test their blood sugar and give themselves regular insulin and is not to live till they're 100 years old, right? For most people, it's they want to go to college, they want to get their driver's license. There's other things outside of the disease state that are the motivating factors. And we have to incorporate those in. And again, we know early intervention and therapeutic alliance, and telling people that recovery is nonlinear, right? And looking at those insights from your lived experience, what helped, what hurt, asking somebody, what's been a good experience with a therapist that you've had? Maybe what are some things that have not worked? And just being open-ended. I think to have those conversations. The psychology of hope. This was a lot of this work was done by Rick Snyder back in the 90s, but talking about it as a parallel system of both agency. So again, the will to achieve one's goals and pathways. So how do we go about achieving those goals? So hopeful thinking requires integrating this sort of our agency and this pathway thinking, and more successful hope usually involves multiple pathways, because we know there's going to be future challenges. We know life is not linear. We know life is not perfect and things are going to be thrown. So again, generating those multiple pathways, having pathways to achieve those smaller goals allows people to experience those positive emotions, to build on that self-efficacy that we know that they will need to overcome various challenges in their lives. And again, looking at this as a clinical tool. So looking at Snyder's hope theory, looking at hope versus toxic positivity. I will never say to people, oh, I loved having diabetes. Diabetes was the best thing that ever happened to me. And because I had bulimia, I'm such a stronger person today because of it. Sure, maybe some of that could be true, but there were a lot of years that sucked and a lot of years that were difficult. And so I am not promoting here toxic positivity, all hope and all rainbows. I think we have to hold both. And that's what I really learned in my years of learning about DBT. And when a clinician can embody that hope, when sometimes as the client, I could not. And then again, really being conscious of our language, the tone, micro moments, again, how we talk about ourselves, how we talk about our weekends, and how that would show up with somebody who may really be struggling. And so I know we're at the very end of the hour. I always say this goes by way too quickly, but kind of reflection prompts as you go back to your workday or go about to your family life. What about this resonated, and what maybe feels challenging to apply, and to think about your own lived experience and some clinical dilemmas you may have had in your practice. And the key takeaways that I hope that you can get from this presentation is that resilience is possible for every single person, and that hope is clinical, and that recovery is real. But oftentimes, as somebody, as the client, I need the clinicians to believe it, to help me see it. And so I want to thank you all for the work that you do every day in providing that hope, in helping people build that resilience, because it is so important. And on my last note, when I was diagnosed at 13 years old with diabetes, I was told I would never be able to have a baby, that, my life was going to be really, really difficult. And I'm in recovery from bulimia. I'm in recovery from alcoholism. I have a beautiful baby boy. And my life has been joy-filled. I've had to reckon with a lot of that trauma from my youth, but that work has been worth it. And so I look to him as the reminder of why this work is critical and why this work works. So I know I'm at the top of the hour, so I'm going to give it back to Tamara. And please, again, email me or message me on any of these social media platforms if we just do not get to your questions. So again, thank you so much.
Thank you, Quinn. We have a little bit of housekeeping before we get to questions. Will you stop share and let me share real quick so folks can see the, here we go. Thank you. There we go. Okay. As I said, we'll get to a few questions in just a minute. Just some reminders. I know there are folks who maybe have to hop off at the top of the hour because of clients coming in, et cetera. So I'll jump right to the QR code. That's a quick and easy way. If you want to scan that with your phone right now, you're more than welcome to do that. That takes you to the post-test link. And so feel free to do that. You can also, when the webinar ends, when you leave or when I end the webinar for everybody, two things will happen. One, in the screen that you're looking at now, the webinar evaluation will pop up. If you'd be so kind as to answer those questions, it'll just take you 1 minute. That would be super helpful. It's completely anonymous, so feel free to be candid in your feedback. It's a CE continuing education requirement for us to gather that data, and then we send it to the CE providers. And then also either when you log off or when I stop the presentation, then a second browser tab will pop up with a link to take the online post test. So if you're watching on your phone or tablet, wade through all those tabs because it'll be there somewhere. And if you can't find it, there's also a follow-up email that will come tomorrow at noon my time, noon Mountain Time, as a reminder with the link to take the post test there. You can scan the QR code now. If you get stuck, just reach out to me and I'm happy to provide it for you. The other thing that I want to let folks know before you go is that we have sort of a special presentation on November 14th. Dr. Nicole Hawkins is doing a presentation, which I feel like goes hand in hand with what Quinn was talking about today, that, hope is a clinical intervention. And Dr. Hawkins is doing a Navigating the Holidays in Recovery, Tools for Hope and Healing. This is not a continuing education webinar. It's a support webinar. So it's for anybody, if you have a client who maybe needs some support, or a loved one, or you yourself could use some support leading up to the holidays. We know that can be a difficult time, regardless of diagnosis. It can just be sometimes a tough time for folks. So you can register for that on our website. We're also, I think, already sent out an e-blast about that, but another one will come. So feel free to take a look at that and let us know if you'd like to join us. We'd be thrilled to have you. All right, Quinn, here we go. Let me get to the answered ones that I did first. Okay, you touched after this is from an anonymous attendee, and after this person sent it, you touched on it a little bit, but the attendee is saying, are you aware of how many of the main issues surrounding supporting clients in their stories of recovery, like what you've shared today, but for people experiencing the other end of the eating disorder spectrum, i.e. binge eating disorder. So, you talked a lot about your bulimia journey and anorexia, and then shortly after that, you talked about language around that, but I wondered if you wanted to address that a little bit more.
Yeah, absolutely. A lot of the speaking I do is in the diabetes world, the diabetes community. And so we know there's a very high prevalence of binge eating disorder. We also know that, like, again, somebody with type 2 diabetes can struggle with various different eating disorders of anorexia, bulimia. However, they may be present. And again, I think beyond just looking at the DSM-5, when I talk to individuals who struggle with binge eating disorder, who struggle with our culture and our society and these messages that are getting inundated, oftentimes they have just given up because they have lost hope. Maybe they went to a provider and had a negative experience where, again, there was the very classic looking at a weight to a height, looking at the BMI and saying, when I was pregnant with Bo, they looked at my chart and they said, well, Quinn, you're overweight, right? And then they were going to tell me how much weight I was allowed to gain or not while I was pregnant. Well, thank God my OB said, disregard this, Quinn. This is ridiculous. You are pregnant. We are talking about how to have a healthy pregnancy. Let's get away from this crap of BMI. Like, how ridiculous. And so again, I think and I tell this to people all over the country, if you've had a negative experience, please try again. Know that just because you had a bad experience, that is not a blanket to all providers. They don't all think that it's your fault you have type 2 diabetes or that you have binge eating disorder. There is hope and there is recovery for every single person. And that's when we need to look at people human to human and look at everybody's opportunities and everything that they deserve, no matter their background.
Thanks, Quinn. Jaren asked the question, what is the PACE acronym? What does it stand for? And I wasn't sure was PACE or ACE or both. So I also would like some clarification. I think there are folks who might want to know more information.
Yeah, I will quick pull up where I was going. So the ACE we know stands for adverse childhood experiences. And I think that was a typo on my slide 11. Sorry, you're like,
that's okay.
And my sister-in-law, her last name is Pace. I don't know if that's what I was thinking as I was typing this. So my apologies.
That's okay. That clarifies it though. That's great.
Hopefully that clarifies it. So take my P out.
Thank you. Okay, this is also from an anonymous attendee. The question is, as a mental health clinician, how can we best build hope and resilience with our clients? My instincts say practice building self-esteem, but curious on other perspectives.
Will you say the first part of that again?
Yeah, as a mental health clinician, how can we best build hope and resilience with our clients?
I think learning about them. Beyond, again, just medical criteria or saying, okay, this is what they're struggling with. I'll never forget an endocrinologist of mine, a diabetes specialist years ago. He would say, Quinn, if I only focus on your blood sugars, if I only focus on your food logs, if I don't understand what's going on up here, the numbers are never going to make sense. And so he said, I have to get to know you. I have to get to know how you got here, how you became you, where you want your future to go. And then he was able to come in, right? Give me confidence, give me sort of a unique approach and also a non-judgmental approach. Not like, how did we get here? This is so frustrating. Like these numbers is, good, bad, they're not adding up. He looked at me like I was a person and that I had had ups and downs like everybody else. I was a human and that he genuinely wanted to get to know me. And that again, as a medical provider, even though he had many more years of education than me, he never made me feel like he was better or he was superior or he had more answers than I did or that his answers were better.
That's excellent. Thank you. We're way out of time and we have lots and lots of, it's all good. It's all good. We have lots and lots of comments similar to the one I'm about to read that I want to end on. This is from Deborah Ann and it says, Deborah Ann says, Quinn, thank you for your courage and vulnerability and sharing your personal journey and insights and for a great presentation.
Thank you so much.
Thanks everybody for joining us. We hope we see you again next time. Bye-bye.